Good morning. It's Wednesday, July the 13th. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. Thanks for joining us on another Open Mics with Dr. Stites program. We are on Facebook, YouTube, and Twitter. Coming up today, two doctors from Ethiopia have come to our health system to learn about trauma care. We'll talk with them and their teacher and explain why their specialized training is so important to their African country. We'll also check with Dr. Dana Hawkinson and find out what our COVID numbers look like today. Questions from our viewers are an important part of this program, and this is a great program. The content here is amazing. We want to hear from you. Get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You find links to those right here on your screen. You may have heard the term academic medical center, I say that a lot, and wondered what that means. It's an organization like ours that not only treats patients, but it conducts medical research and trains physicians, nurses, respiratory therapy, social work, dietary, physical therapy, and others in many different specialties areas. Here's a perfect example of that. Two doctors from Ethiopia are here to learn the latest in trauma care. It's vital because Ethiopia is the second most populated country in Africa with 45 million people. But there are only 87 hospitals with just over 11,000 beds to serve the entire country. This training is so unique, film students from KU and Lawrence are making a documentary about it. Joining us this morning are orthopedic trauma fellows Dr. Abby Hiley. I knew I was going to do that. I knew it. Okay, Abby Hiley, not bad. I got it right the third time anyway. And Dr. Solomon Mengistu, right? Okay, there we go. Also, the International Orthopedic Trauma Fellowship Director and one of their teachers and one of our orthopedic surgeons, Dr. Archie Heddings. Plus, we're going to talk with a medical student, Ravali Reddy, whose research explains why trauma surgeons are in such demand. And you'll meet another African physician, Dr. Terence Epi from Cameroon, who is currently working on his MBA from the KU School of Business. We're going to find out about how all these people came together to help healthcare in Ethiopia. So good morning and welcome to all of you. Dr. Heddings, let's start with you. Explain to us, what is a fellow? How is that different from a resident or a medical student, et cetera? And how the heck did this even get started?
So when you're talking about a fellow is someone who's completed medical school. They've completed a surgical residency in a particular field, such as orthopedic surgery. And then after that residency, they've gone on to 1 to 2 years of additional training to gain mastery in a particular subspecialty within that field. So in our case, orthopedic trauma surgery.
So the International Orthopedic Trauma Fellowship, how did that come about? Because I was thinking, that's a lot of words, but it's pretty cool sounding.
Yeah, so the way it came about was through a progressive understanding I developed over the course of my career from 2006 to present, working in global health, trying to figure out how to improve healthcare disparities in low to middle income parts of the world. So out of that understanding, it basically started with me first trying to get into global health, realizing that it was very difficult to go on mission trips and perform orthopedic trauma surgery. And then from there, just searching, I developed a relationship with a trauma center in Romania, and that began in about 2014. And then through my relationship with the trauma surgeons in Romania, in which we did collaborative training, collaborative research, and then acquisition of medical equipment, I was able to just observe this process that we developed where we could take a hospital in a low to middle income part of the world and bring it up to where its outcomes at that trauma center could equal the outcomes at a trauma center, at a state-of-the-art trauma center like ours.
That's impressive. So how did you get connected to Ethiopia?
So Ethiopia, I got connected with Ethiopia through our Office of International Programs at the University of Kansas. We have a very robust Office of International Programs here, and I was put in touch with the trauma hospital in Ethiopia. Basically, I was asked if I would be willing to go over there and do some training in pelvic and acetabular surgery.
That's a pretty big deal. So, Dr. Haile, you are from Ethiopia. Tell us a little bit about your country, your home there, and how do you ended up 8,000 miles away in Kansas City, Kansas, of all places? Which, by the way, is a great place.
Yes, it's a great place. So I came from Ethiopia. Ethiopia is found in eastern part of Africa. It's it's called the land of origin because one of the oldest skeleton of human was found there. That is a Homo sapien, around 3.2 million years ago, was supposed to live 3.2 million years ago.
And you didn't try to do trauma surgery on that skeleton, right?
No, I
Okay,
didn't.
just checking.
So Ethiopia is the only country in Africa which was not colonized, and because of this, most of the cultures and there are unique things about Ethiopia. So Ethiopia is now the headquarters for African Union, and it's one of the founders of African Union, and we have like a beautiful country which is 30 months of sunshine. It's called 30 months of sunshine because we have our own calendar, which is 13 months, not like this. It is not like 12, but it's 13 months, and it is one of the few countries in the world with its own calendar, and it's also we have also our own language and with our own alphabets. And it is one of the fastly growing African countries with GDP estimated to be around 8 per year. That's an average.
That's a lot of growth. That's awesome. So how'd you get to KU?
So I came to KU because, unfortunately for me, I had a chance to meet Dr. Heddings when he traveled to Ethiopia, I think in 2018-19. When he came there, we had a brief meeting. I only met him for 1 day at that time because I was working in different place. But we had a good relationship. Then the relationship built, and we were talking about the future plan for fellowship. Then when finally the fellowship came to be true, we came here for our trauma fellowship study.
That is amazing. How long were you here?
For a 1 year program.
1 year. That's excellent. All right. I love the relationship, and he's a pretty good guy, actually, huh?
Yes, he is a really good guy.
Yeah, yeah. We have to give him some credit now. Dr. Mengistu, did I say it right? Mengistu?
Yes.
Okay. What is your medical practice, and how did you come to be an international trauma fellow?
Okay, thank you for having me. And I was started medical practice after completed my high school.
Speak louder. Speak louder.
After completed my high school and undergraduate MD education in Addis Ababa, the capital city of Ethiopia, then attended my orthopedics and trauma surgery residency program at Faculty of Medicine, Addis Ababa University in Ethiopia. Then I have been serving for my country for the last 3 decades as a general practitioner and also as...
Borrow this from me for just a minute. There you go. Keep just talking. Just hold it like that. Just hold it up here. Just hold it right here.
Okay.
Yeah.
Okay. Better for me. So as orthopedic surgeon with different level of position as undergraduate and postgraduate coordinator, as a medical director, as regional and zonal department head. And before coming here, I was permanently working in Ethiopia as a senior consultant, assistant professor of orthopedic surgery in St. Paul Hospital Medical College.
And you're the department head too, is that right?
Yeah, I have been in
So
department
you're like a
head.
really
I
big
have been
deal back home.
deputy medical director.
Yeah, you're a big deal back then.
So St. Paul Hospital, Millennium Medical College, and Abiet Hospital, one of the major and the biggest referral hospital in Ethiopia. So our patients coming from every corner of in Ethiopia, and the patient visiting our hospital almost from every corner of Ethiopia. Most of our patients are high injury and complicated patients, so we are in difficult situation managing them because we don't have the knowledge, the skill, and the minimum standard medical equipment to treat them. So most of our patients ends up with malnutrition, malnutrition, and deformity, and also death. At this junction of time, in August in 2018, Dr. Heddings, he was in an international orthopedics mission campaign and in Ethiopia, and he did a lot of surgery, and he was seeing a lot of patients with deformity, disability, and infection. And then he did only 10 or 15 patients within 1 week. And then he learned that, and he decided that he couldn't achieve anything only doing for 10 or 20 patients. So he started organizing fellowship program here. And it takes a lot of, almost more than 2 years. And that is why we are here, and we become an international fellow, trauma fellow.
That's a big deal. I love the point you made. He could only do 10 or 15 patients a week, but if he trains people to go back and do it, they can do hundreds of patients and thousands of patients, and then the knowledge spreads, and it's like that ripple in the pond. So that's a big deal. Dr. Heddings, talk to us a little bit about that program and being part of the African Trauma Initiative. I'm impressed. This is cool.
So, yeah, Dr. Solomon spelled it out very well. It's this understanding that's, I think, developed as we've done international work and tried to help out lower middle income parts of the world. It's not enough just to travel and operate for a week. We have to make something that is self-sustaining. And their trauma center literally serves millions of people. You can't take care of all those people in 1 week. And they are very accomplished surgeons. They can do this. As our model in Romania showed, if you do adequate training and provide adequate equipment, you can deliver the same level of care in these parts of the world as you can here. So it's out of this understanding that we launched the African Trauma Initiative, which I launched with a number of medical students and KU students all around the KU health system and the KU University. So we have lots of people involved. We have people from the Department of Economics. We have people from the School of Business who you'll hear from. Of course, lots of medical students, and they're all coming together to help to train physicians from other countries, do research, and obtain the equipment they need in their hospital.
That's an amazing story, and I love the idea. It's like Johnny Appleseed, right? We're spreading a few seeds, and those seeds grow, and they feed a village. So tell us a little bit more, guys. Dr. Haile, how does it feel to come back acquiring these skills, knowing you can take that back to Ethiopia and help folks?
So it is a dream come true. We were not able to help some of the patients because we didn't have the training for complex traumas and for especially for pelvic acetabulum cases, and we were referring this patient to other centers with their trauma. So now being able to practice and to see how to do it and to practice is going to help us a lot to get these patients well and go to make this patient able to go to their work or to their school. Since most of these injuries occur in young patients, getting these patients active again is going to help with the economy, with the social life, and it's going to support their family. So it's going to make a lot of difference.
And make a better place.
Yes.
That's great. Jess, I bet we have a few questions about that, so I'm going to turn to Jessica, to Studio B, ask Jessica Lovell, what are you hearing?
Well, good morning. Barb has kind of a fun question, and I want to know myself. How long have the doctors been in Kansas City, and what do they like so far?
All right, Dr. Migasu, what do you think? How long have you been in Kansas City now?
I've been here for 8 months, and here is I am interesting. The people are good, and we have a lot of friends in Kansas City. We are visiting our friends, not only from America, and also our citizens from Ethiopia also, and we are enjoying here, and I think very interesting for us learning here medical orthopedic surgery and living together with a good community and with nice friends. And we are also communicating with Dr. Hedding. We are visiting his home and his family, and very interesting for me.
That's good. Have they taken you guys out for barbecue, just to ask? Have you had barbecue here in Kansas City? What's your favorite barbecue so far?
Yeah, Mongolian barbecue. For
Mongolian barbecue, okay, fine. You're supposed to say Gates barbecue. That is the best. Dr. Hiley, how about you? What's been your best part about Kansas City so far?
So the people here are friendly. That is a good thing, and the city is a beautiful city. And the hospital, the thing is the hospital, it is very big hospital with the equipment, and everything is very fancy, and it's very nice to see and to have this all experience. And the only thing that was difficult was the winter. It was very cold.
It was cold here for 8 months. Yeah,
yeah.
there you go.
Otherwise, we are having a good time here.
How about the summers? It's getting pretty hot right now. Is that hot? But Ethiopia can be hot too?
The summer, we can handle it. I think it's not that bad.
it's the winter.
Our country is a tropical country, so we can.
All right. Jess, any other questions before I turn to Doc Hawk right now?
I've got a couple of COVID questions, so go ahead and get to Dr. Hawkinson. Maybe he'll answer them.
All right, Hawkeye, how are we doing this morning?
We're doing good. You know,
it's not bad.
the health system could be doing better. You know, we've really hit in that middle 20s, Steve. You know this for the past few weeks. I'm being optimistic and hoping it's going to go down in the next couple weeks as well, because we've just been sustained here for a little bit. But 25 active infections, 2 in the ICU, 1 on the ventilator, 9 in that recovery period. And again, we know that the actual reported cases have really been at a plateau for the past few weeks. And obviously we understand as well that there are unreported cases because of at-home testing or no testing at all. So really the hospitalizations tend to be the best benchmark.
Yeah, I agree. I think the numbers are all lower, though we know the community rate of transmission is so high, but we aren't doing that much testing, or it's at-home testing. People aren't talking about it as much. But hospitalizations aren't where they were a few months ago when we were down to 2 or 3. So we do have a lot more, but our death rate is staying relatively low. And I think it's the overwhelming large percentage of people now who have been vaccinated who have really helped that.
You know, absolutely, I agree with that. And Amanda Cackler put together those numbers last week from one of our days as a snapshot, and just looking at those that were up to date with vaccination, and none of our hospitalized patients were actually up to date with vaccination. So
yeah, I think that is all that makes such a difference. Then I read this morning that President Biden is thinking about not shaking hands when he goes on his Middle Eastern trip. I don't know. It feels like surfaces aren't the issue. I think we've really learned it's all about respiratory precautions.
Yeah, I would totally agree. It's respiratory precautions, shaking hands, those things really don't pose a threat. But what is important about that? Again, general public health guidance, absolute excellent hand hygiene. You can carry some alcohol hand gel with you, shake hands. Use the alcohol hand gel and you should be fine.
Yeah, now the administration is talking about opening up the second COVID booster to everyone in the country.
Yeah.
Thoughts about that?
Yeah, it's interesting. Again, you know, there are still people who think that is not needed. Obviously, I know that we have good data to support the fact that if you are in that older category. So right now they have 50 and older, but it's especially those people who are, say, over 65 who really benefit the most from those additional doses. And I think we're just really kind of waiting to see what happens with the overall recommendations. But I saw that as well, and wait to see what the headlines are. What the final recommendations will be for that. And I think in the next few weeks we should have some of that information.
One thing we know is the BA5 is now dominating the country. It's probably over 2/3 of infections now. Are we more concerned about that one? Because it feels like to me I'm not. But
yeah, no, I don't know. I think the media certainly is. We know that infections, just like you said, infections are dominating now. It is starting to become the more predominant. But what we have from the UK and the South African experience is that they really didn't see a rise in severity. Preprint that is not peer-reviewed yet looked at that, and really there's no more severity than Omicron. We know Omicron was less severe than Delta, but what I mean by that is with Delta you did seem to have a higher risk of hospitalization. But what is important now we have that vaccine immunity with people who are boosted and up to date with boosters, but also those people that have been infected and vaccinated or infected and reinfected. I think that really helps with individual immunity overall to help reduce your chance of hospitalization. But I'm not really, I don't have too much of a concern about that if you are immunized to SARS-CoV-2. We know that these original strains, this original Wuhan spike that is present in the vaccines, still continues to offer very good efficacy against and reduction in hospitalization and severe disease.
I'm going to posit a theory. I want you to be critical of my theory or thought, or you can be supportive of it if you like. How that goes. Yep. So if you look at what the CDC is saying right now, we have a pretty big blind spot about the actual number of cases that are out there. There are probably a lot more than we think, and because it's underreported, people doing home tests, all that reason. I suspect that the community prevalence of B5 is probably higher than the alpha strain at any one time. That is, there are more people currently infected with B5 than there ever were at one time with the alpha strain, the delta strain, the beta strain, or all those others. And yet hospitalizations are much lower. In fact, if we had this many people who are sick all at once with influenza, I think we'd have a whole lot more influenza people in the hospital. So it makes me think we clearly have reached a different equilibrium here in the United States around with the BA5, because we just keep getting one variant right after the other.
Yeah, I think that's reasonable, and those variants really tend to be the same clinically as far as chance of hospitalization, severe disease. Again, Delta was maybe a little bit more, but I think all of the rest have really been similar clinically, but it's more of that now individual immunity. So I think that's certainly.
I think that's right. You know what else we know? The rules of infection control still keep you safe wherever you go. Jess, any other COVID questions?
Yeah, Jean wants to know concerning what the CDC is showing, that April deaths from COVID were close to 55%, and those people were fully vaccinated. Can Dr. Hawkinson talk about if he agrees or disagrees with that finding?
I think that's a confusing statement.
Deaths were 55%. Yeah, I don't understand. It's not 55% of cases. That's a high case.
Nor was it
fatality
55% of hospitalizations.
Right. So the latest that I looked from the New York Times, they still have a vaccine. They still have those vaccine charts, and your risk of death continues to be 2 to 5 times higher if you're unvaccinated and not updated.
So the other problem is it's almost impossible now to define what vaccination means, because people have been, if they have 2 vaccines, but it's been a year, are you still vaccinated? Technically you are. And so when you look at the data, you get people who are vaccinated, but it may have been a long time since they've had a booster. Second point, some people have been vaccinated and had COVID, and then maybe they've had a booster or not. So the population, when we first started this, it was very easy to compare the populations. It's not easy anymore. I think what you have to start doing is looking for big picture trends. And what we know is, just on our own data and data around the world, the more vaccinated and boosted you are, the lower your risk of death and severe hospitalization. The less vaccinated, or if you're not vaccinated, you're only relying on native infection, then your risk of death and hospitalization is higher. And if you've neither had vaccination nor been infected, you have a really high risk of having, just as you would have had the original part of the pandemic, which I think just says that the current BA.5 is really not that much different than the original strain in terms of the severity of disease.
Yeah, I would agree with you. And we've certainly been touting and talking about vaccine. I think we should also mention that we do have outpatient therapies now that continually help reduce your risk of hospitalization. Maybe underutilized, but we know, especially if you're in those high-risk categories with age, other comorbid conditions, that Paxlovid, that outpatient therapy, can help reduce your hospitalization. And of course, an alternative therapy is that monoclonal antibody as well.
Yeah, it does work. Okay, Jess, anything else?
Yeah,
before we move on?
do vaccines give you acquired immunity?
I don't know what they mean by acquired immunity. It's not the same thing as natural immunity, but it's great immunity.
Yeah, so you're acquiring immunity from the vaccination, from that spike protein. We know that if you're vaccinated, that's what you have. If you get the infection, you're acquiring immunity to not only the spike, but other pieces of those viruses as well. So I'm not sure the exact nature of that question, but yes, you are acquiring immunity either from vaccination or infection.
And then, real quick, Sue has a question. She says, my husband and I had both shots and boosters. We had not gotten the second booster before then getting COVID. Should we still get the second booster? And if so, how long should we wait post-COVID to get the booster?
It's looking more and more like at least 3 months post that last infection.
Yeah, and certainly, I just had to answer this for a person in the hospital right now who had it in June. So I think that's a good question. I think the CDC would still recommend you are able to get that booster after 10 days of that acute illness, mostly for that isolation issue. But I think there's also a loose recommendation is you are able to wait, say, 90 days. I think we've really kind of landed on anywhere from that 8 to 12 week range. It is still recommended to get the vaccination. There are experts who debate about that, but the CDC recommendation would still be to get vaccinated.
And just to say, I think some evidence, if you in the New England Journal of Medicine discussed this last week, that really the most important thing are the 2 shots and at least 1 booster.
Yeah.
That clearly, and then the 4th booster is good, but man, it's really 2 shots and a booster 4 to 6 months later is a really big deal, and that really helps keep you safe.
Yeah, and that's kind of what we talked about, that 3 exposures to spike. So 2 with that primary series and then 1 with that booster. So you're exactly right.
All right, let's get back to our conversation now with Dr. Archie Heddings, an orthopedic surgeon here at the health system, plus doctors, I'm going to say this right, here we go, Abi Haile, yes, and Dr. Solomon Mengistu. Okay, there we go. Both orthopedic trauma fellows from Ethiopia, full-fledged orthopedic surgeons who are here doing additional training for 1 year so they can take that trauma experience back to their home. Also joining us live via Zoom is is Ravali Reddy. Not yet a doctor, you're a medical student still. She is here at KU. And now I'm going to say this right, Dr. Terrence Epi. Do I have that right, Dr. Epi? Is that correct?
Yes, correct.
All right, not bad. He's a physician from the Central African country of Cameroon. Ravali, you've been researching the burden of trauma as part of the African Trauma Initiative. Tell us a little bit about that group. So you've got some graphs. Tell us a little bit about your research too.
Yeah, so just as the group itself, the African Trauma Initiative has really been a collaborative effort from the start. I mean, Dr. Heddings talked about the partnership between the hospitals, but at the same time, we have a collaborative effort from the surgeons that are sitting with you in the studio, but then also students just like me from the KU School of Medicine. And then we have other key players like Dr. Terrence Epi, who's a physician from Cameroon and is working towards his MBA. So everybody has different skill sets and is working together for this. But when you consider the African Trauma Initiative in total, Dr. Heddings touched on this, but it is a combination of a post-grad surgical program. There's a collaborative research side to this, which I can talk about, but then there's also ultimately obtaining the medical equipment that's needed. And kind of that's what encompasses our group.
That's impressive. So Ravali, what year of medical student are you?
I'm going into my 2nd year.
Okay, well, you've done a lot of work, man. Medical curriculum is hard enough, but be doing this type of work and this project along with your medical school curriculum, hats off to you. What do you want to do in your life, do you know?
I'm hoping orthopedic surgery, but I think that things like this are possible with mentors like Dr. Heddings.
Yeah, that's pretty impressive. Just to point out that Hawkeye and I are both internal medicine doctors, and that's also the best job in the entire world.
Yep.
I don't know if it's an ID or
Absolutely.
pulmonary, but just a thought, just in case you think about things down the road a little bit. Dr. Epi, what is your medical specialty?
Yeah, thank you. So after my medical training, I went to the University of Oxford, where I did a master's in international health and tropical medicine.
All right, so that's kind of like infectious disease. We're all about that. That makes you an internist more like us. It evens the score. Now it's 4 against 3. All right, so tell us, you're taking a little different approach to helping your fellow citizens back home. Why your MBA from the KU School of Business? How is that going to help training and care and things like that in Cameroon?
So I think the pandemic has shown us that particularly there is over-reliance on foreign aid for financing global health programs in Africa. And there was need for us to start thinking about sustainable ways of health financing. And it is on that background that after my medical training and my experience in international health, I thought it wise to get a training in an MBA training, so that it kind of gives me more opening on how can we develop models that will be efficient in financing global health programs. So that is kind of from that back end.
All right, that sounds like a great thing to do. For those of us who also have to do some administrative medicine, I think it sounds like you're going to go do some good administration. You're going to carry all this knowledge with you and help develop systems of care that can help everyone. That's pretty cool stuff. So what funding opportunities are out there and available for the African Trauma Initiative? Who helps fund all this? Who pays for it?
Yeah, so the African Trauma Initiative, it's a very great initiative, as has been highlighted already. And generally in financing global health programs, there are kind of 4 models that could be used. And we are in the African Trauma Initiative, we are trying to combine all 4 models to make them sustainable. And the first of them is what we call private funding. And usually this is from community members, individuals, or families who have some money and they are passionate about addressing the health challenges that are found in communities, be it their communities or abroad. So that is one possibility that could be used to be able to finance the African Trauma Initiative. The second is using organizations or businesses. This could be businesses that kind of have interest within these countries where the African Trauma Initiative is taking place, or it could just be multinationals who are passionate about their corporate social responsibility and want to effect change within the world. So that is the second model that could be that is possible in financing the global health, the African Trauma Initiative. The third model is using funding agencies. We know, for example, the USAID, for example, in 2020 provided funding to Africa at a tune of about $8.5 billion. So some of these could go towards funding initiatives like this. Not forgetting that we know the trauma or injury is currently an epidemic in Africa, knowing that about close to generally about 4.4 million people die every year from injury. And 93% of those persons are in low and middle income countries. So there's a huge burden. And some people have qualified this as an emerging epidemic. So also to note here that the last model that we are trying to look into is the model for partnership. This is collaborative partnership between manufacturers of medical equipment and orthopedic implants. If I can take a step backward and try to put on my my MBA cap, you will see there's a market opportunity when we look at trauma care in Africa. We know that the market size for orthopedic implants is about $42 billion, and the compounded annual growth rate is about 5%. So you see here that if 93% of these trauma cases are occurring in low and middle income countries, therefore companies who are able to invest on providing equipment and training for these countries are likely to penetrate this market and achieve that economic of scale, which will make them more profitable. And at the same time, they're also going to resolve or to address the economic issues and the emerging epidemic that is related to trauma. So there's a win-win here for collaborative partnership between the African Trauma Initiative and medical equipment manufacturers and implant manufacturers. So we are also calling here on them to join us to be able to address this emerging epidemic in Africa. Thank you.
Yeah, that was great. And I love the point about from a financial standpoint, even companies can win if they help get people trained in that. They take back those skills and they'll need some of that equipment too. Dr. Mengistu, talk to us a little bit about what you've learned so far.
So we have observing in operative room complex surgeries like hip surgeries, long bone fractures and short bone fractures and joint fractures with excellent outcomes. And we are observing also surgeries with the state-of-art implants and orthopedics equipment. And also we are attending in outpatient service clinics and attending in teaching conference, lectures, and sharing our experience for residents. And also we are attending in national continuing medical education courses. And after observing cases in operating room, we are practicing hands-on training in cadaver lab. And also we are involving in collaborative research programs. Now currently we are doing surgery with pain study, comparing pain score after operation in Ethiopia and in United States. We are also developing knowledge attitudes practice for traditional bone healer toward this modern medicine. And also we are in projects, we are developing projects on barrier to obtain orthopedics implant for developing countries.
That is really, that is great stuff. And so Dr. Heddings, I think we have some video we want to show. If that, we can cue that up. One of the first times you saw the table full of all these surgical instruments, it looks like there's probably a lot more to choose from than maybe what you had at Ethiopia. What did you think when you saw that OR layout?
So it was overwhelming to see all those instruments come out for fractures to be fixed, because we usually use few implants, few instruments, and we have a limited setup, so we have to use and try to manage a lot of patients with few instruments that we have. So it is overwhelming, and I thought that they are very lucky, like orthopedic surgeons practicing here are very lucky to have these all equipments and to be practicing here without stressing about what to do for the patient, because you don't have the equipments and you get frustrated in the middle of surgery because some of the implants or some of the instruments may not work and you may need to change it to the other, but you will not have those options in our setup, and you have to go with what you have as the first, and you have to, so this will lead to lower outcome. Like the patient may have disability because you didn't get the proper implant or instruments in the setup. So in the video it shows you there are different plates or nails. These are the instruments that you use for fracture fixation. So we don't have those a lot of options, so we have to minimize our cost and try to use few implants as possible, and this leads to a lot of complications.
Yeah, the choices in the equipment does help make the difference here. So, Ruvale, just a question for you. Tell us, what is the actual research project you're involved in that you're specifically looking at?
Yeah, so within our research group, there's 4 projects that are associated with the African Trauma Initiative. One of those that Terrence had mentioned was more of a narrative paper that's looking at the process of how this came about, the business and economic side, because there's been challenges with contacting companies, figuring out pricing, etc. It's something that hasn't been looked at before. Another one is within our research group, some other students are working on a traditional bone setting study. They're looking at the knowledge, the attitude, and the practice surrounding traditional bone setters, as well as modern orthopedists in Ethiopia. And then we additionally have a pain study. This is a comparative study between the United States and Ethiopia, and they're comparing patient outcomes, specifically at 24-hour pain ratings, as well as the types of medications that are being used. And then finally, our fourth one is kind of a little bit of a newer project. This is a study that's looking at the cultural meaning of the value of life, trauma, health, and death. And so this is a very different approach, but if we do want to make this a self-sustaining program, we need to consider and really learn and understand the different cultures here.
Yeah, that is a remarkable story. Well, thank you guys for that. Okay, Jess, let me turn back. Any questions from our community or any reporter questions out there today?
I have just a few. Brenda wants to know if Dr. Hawkinson knows the age range of those infected in the hospital, even if we know here locally or just nationally.
Yeah, it's the same age range we've seen, right? From a little bit, what we know is there's clearly a higher preponderance of those over 60, especially those over 70.
Yeah, I don't have that data available from our last check, a week ago. I'll certainly look through and see if we can, but again, that data is going to be a week old. But I would agree with you, Steve. I think it's the same type of age distribution.
Yeah, if you look at the New York Times, they've got that age data in there, and what it demonstrates is that the numbers continue to go up as far as a percentage of the population. You're most at risk if you're over 60, especially if you're over 70. So I'm still not at the most at risk category, but I'm holding on tight.
Yeah.
Just barely. Jess.
Ruth Ellen said that she had her wellness check yesterday, and she's 67. Her doctor talked to her about the pneumonia vaccine Prevnar 20. She wants to know what you know about it, because she said the doc said to check with her insurance company because it could cost about $800.
Yeah, so it's the new formulation. We are going to be go live with the health system here, I think in August. Right now there are two we call them pneumonia vaccines. What they are is they are vaccines specifically directed towards strep pneumoniae, which is one of the most common causes of pneumonia. It doesn't necessarily protect you against pneumonia itself. What it protects you is those extreme complications that can make you very ill and go to see Dr. Stites in the ICU. Those things such as meningitis and bacteria in your blood, but also on your heart valve. So they work extremely well for that. Right now there are two. One of those is Pneumovax. The other one is Prevnar 13. We will be going to just the Prevnar 20, but I would absolutely recommend, if you are in the category to get those vaccines, to go ahead and get them. Again, right now there are two that you have to give, a few months apart. As soon as we have the go live with the new Prevnar, we will be using that in the hospital almost exclusively. So yes, absolutely good. Absolutely is life-saving. The side effects are extremely minimal. It is just pieces of the bacteria. It is not even the whole bacteria, so I would recommend getting that. But you can certainly, if you would still like to use the older ones, that is reasonable too. Those should be a little bit cheaper for insurance coverage and whatnot.
Eventually it'll be the same. I mean, insurance does a pretty good job of covering these Prevnar shots. So Jess, let us take that back, because it shouldn't be $800 to an individual. Let's go find out a little bit about that. Okay,
update us on that for sure. And then last question is from Tien Liang. Wants to know, could monkeypox turn into the next pandemic?
Yeah.
Go ahead.
Yeah, I don't think there is any concern at this point that it is going to turn into the next pandemic. Number one, we have excellent vaccines against it. Those vaccines are the smallpox vaccines. We know that we have great stores in the United States of those vaccines. We also do have antiviral medicines for those people that may be having severe disease or abnormal presentations. But remember, it is not spread through respiratory droplets or the respiratory system per se, like SARS-CoV-2 is. Certainly there can be some respiratory spread, but the vast, vast majority of spread of monkeypox is through those close encounters, those skin-to-skin encounters, sharing clothes, sharing bedding, things like that. There is right now no concern that it's going to be a pandemic, but what we should also make clear is that it is concerning. It is concerning if you get that. It does cause pain. It does cause you to have to be out of work and things like that. But right now, we have very good ways to help mitigate that and stop the spread. We know that the Health and Human Services is working on rolling out vaccine programs for that. So the bottom line is right now there's no concern that it's going to escalate to the pandemic such as SARS-CoV-2.
And I'll just say, I think you hit on the most important point. For a pandemic, for a true pandemic, you have to have both a high possibility of harm and a easily transmissible disease.
Yeah.
Monkeypox doesn't really have a high harm.
Yeah.
And it's actually pretty hard to transmit. It is not, you have to be in this,
Yeah.
to be respirable, you have to be in front of the other person
Yeah.
within close contact for more than 3 hours.
Yeah.
Or
Absolutely.
you have to have skin-to-skin contact with open source. And this is a harder one to transmit, actually, and it's mostly a little bit more around recklessness that leads to transmission, as opposed to 5 minutes of exposure with somebody who you're just kind of having a conversation with. So it's really a completely different virus. It's a completely different transmissible event.
Absolutely. And I heard a good comment the other day on TWIV. They had Paul Offit on, who's a great person about vaccines, and talked about the vaccines as well. But he also said, a pandemic is really defined as a changing in the way we live our daily lives or what we go about doing. This should really not necessarily change for most people and impact the way people are living their lives.
Yeah, it's nothing like SARS-CoV-2. Jess, last question.
Last question. Karam has a question for our African Trauma Initiative team, our guest today. What is the one thing that is missing that you believe could really significantly help advance this project and initiative?
Dr. Mengistu, what's the one thing that's missing that can most advance this whole project, do you think?
Especially we need more training and also hands-on training. Especially we are observing here.
Yeah,
So
being able to actually do the surgeries would be
do the
approximately a
surgery.
very big
Yeah,
deal.
yeah.
Dr. Hiley?
Getting the implants will be the biggest next step, I think, for
Okay.
me. That unless we get the implants, we have seen when we are able to practice most of the cutting-edge technologies with orthopedics here, but when we go back home, we have to face the hard truth and face that even now the CRM was not functioning for a couple of months since we came here. It's not like the intraoperative X-ray machine is not functioning. So this is one of the most important tools in orthopedics. So when we go back home, it's the things that will be lacking is to have the implants and instruments.
Well, I'm going to turn to Dr. Epi for just a moment. So, okay, Dr. Epi, I hear the job that you've now been challenged with your master's: equipment, more training, and the right implants. So I think that you have to figure that out while you're here.
Yeah, so as everyone has identified, those are our big challenges. So it's now for us to come together as a community and respond to, these challenges that are put before us. We are calling on individuals, we are calling on families who may want to donate, we are calling on organizations and the different partners that we highlighted, orthopedic equipment manufacturers and implant manufacturers, to come on board for us to collaborate to ensure that we bring to an end the trauma epidemic that is currently happening in low and middle income country. I always want to remind that more than 93% of the overall 4.4 billion deaths are occurring in low and middle income country, and it is high time we bring an end to this emerging epidemic.
Yeah, that sounds like great advice and great thoughts. I want to thank our first-year medical student from KU, Ravali Reddy. And by the way, Ravali, there's still time to see the light and do medicine, but I have to say after today's program, orthopedic surgery sounds pretty darn important too. I know it is, especially as I get older. and Dr. Terence Eppy for joining our discussion today. Dr. Eppy pursuing his master's in business administration. He's from Cameroon. I want to start with our guests here in the studio with final thoughts. First, Dr. Heddings, first of all, what a program. Congratulations, well done.
Thank you. Final thoughts are, if you want to give now, there is an endowment set up. It's called the Dr. Heddings International Support Fund, and you can give through the KU endowment to that because the African Trauma Initiative is in its infancy right now, and we are in a battle to raise money to keep this project going. So anything you can give would be greatly appreciated.
Yeah, thank you, and thanks for doing all this. And these guys do you see a time where they can do more hands-on training, not just observation?
It will take changes in our laws. Currently, the way the laws are written, they cannot actually practice medicine here, but we embed them within our clinical teams. And the surgeries that they observe in the operating room, we then perform realistic cadaver surgeries in our lab. So I think it's a pretty good experience.
Well, and he said very accomplished trauma surgeons. These guys are both great orthopedic surgeons, so that's going to be helpful, help as best we can. Okay, Dr. Mengistu, final thoughts.
Oh, okay. Currently, trauma has become one of the leading causes of morbidity and mortality in Ethiopia and in Africa. So, especially if you see in our country, the waiting time for surgery increases dramatically. For example, for long bone fracture, the patient must wait up to 4 and 8 weeks. If you see here in KU, long bone fracture, an emergency procedure. So for elective surgery, sometimes the patient waiting up to 2-3 years. So that is a very difficult situation for the surgeon and for our patient. So we have to solve the issue by organizing Africa Trauma Initiative and also by raising fund for these difficult situations.
Yeah, a great venture for you to continue to take on, and thanks for being here and thanks for being on our program. Dr. Hiley.
So with the good fortune knowing Dr. Heddings, we were able to come here and improve our skills and knowledge in different trauma management, especially in complex traumas. But like when I go home, there are going to be now we have more than 4,000 patients on waiting list to be operated because we don't have the proper instruments and implants which are waiting. They are listed on paper and they are waiting to be called on and to be operated. But they don't have this chance because we don't have the proper implants and instruments available for them. So getting the implants and instruments is going to help us alleviate their pain, and these patients are disabled. They are not able to help their family or go to school if they are young and they are not going to school or going to work, and they are not living their life. These are young people, usually age between 15 to 55, most of them. Some of the patients die waiting for the surgery, so it is very sad to be facing these challenges at home. So it is, I think, high time for the community and the world to help in what they can to improve the health facility and improve the quality of care in trauma, especially in Ethiopia.
Yeah, thank you. Dr. Hawk, final thoughts.
I worked with, last week we had Dr. Bobsar on. This week, Dr. Heddings. I work with both of them, collaborating. Dr. Heddings is a great surgeon, a great thoughtful person. So just a great thing that he's doing, and it's great to meet these other physicians from around the world. And hopefully, we just continue education and trying to make people's lives better and improve their quality of life.
I'm always impressed that even when you feel the world is being torn apart, and you find the people who are putting it back together. And I want to say a special thank you to Ravali Reddy, Dr. Terence Eppy, Dr. Abi Hiley, and Dr. Solomon Mengistu for being here.
I would like to say thank you for USA people and government KU University and Department of Orthopedics and Sport Medicine and the Office of International Program, and also Dr. Hedding and his family.
He is family, isn't he?
Yeah.
Thank you. You know, there's things that take us apart, and they're the things that put us back together. One of the things that puts us back together is grace, unmerited favor given to each of us to try and work together and to do good works. And it is such a joy to see this, because the more there's grace and the more we work together, the harder it is to tear us apart. Speaking as someone who demonstrated that throughout their lives, I want to offer special condolences today to the family of Dr. Chris Perryman. Chris was the Chief Medical Officer for St. Luke's Health System for a number of years. He was a good friend of our families. I knew his daughter, who was a physician, I believe an otolaryngology resident here at KU. She was also a soccer player, and somehow I didn't ruin that when she was younger as her coach. This is a wonderful human being and a wonderful family. He did a great job. He was also the Senior Vice President at St. Luke's. Chris was the doctor's doctor. He was just an absolute icon in our community and a great physician. He passed away last week at the age of 72. He is the essence, like Archie Heddings, of what being a great, graceful physician means. And he was a terrific leader in our community. Chris Perryman will be missed. Don't forget, you can catch our programs anytime by logging onto Facebook, YouTube, and Twitter. Tomorrow we look back at the incredible journey a Chicago man made to the Kansas City area to save the life of someone he didn't even know in our special encore episode of the Morning Medical Update. We'll be back live Friday at 8 a.m. I will see you then. Hawkeye, the team, have a great day.
Celebrating a big milestone. The first adult patient to receive proton therapy at the University of Kansas Cancer Center crosses another milestone, and we were there. Lisa Webb becomes the first to ring the bell at the region's only proton center. We'll check in with her and her doctors Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.